Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series in neurology, today we'll be discussing on examination of reflexes, particularly in person with upper motor neuron damage, that is corticospinal tract damage, which can be at the level of cerebral cortex or corona radiata or internal capsule or in brain stem up to anterior spinal horn. You will have common findings. We call that as upper motor neuron damage, and will have effect on both types of reflexes, that is superficial reflex as well as deep tendon reflex. So we'll be discussing on that particular part. So it will cover up both. So reflexes in upper motor neuron lesion, superficial reflexes and deep tendon reflexes. So first we'll be discussing on superficial reflexes, and then we'll be talking on methods as well as what will be the findings, and we'll be discussing on deep tendon reflex also in upper motor neuron lesions. So component of superficial reflex is activation of sensory receptor by a stimulus, and the most common stimulus is touch or deep pressure. Then there is an activation of sensory neuron, information is processed, and then you get activation of a motor neuron and you get a response in the form of contraction of a muscle. This is superficial reflex, where you can see that there is a stimulus like hot object. The impulse will pass all along. It will go to the posterior horn. This is a posterior horn ganglia. Then it will make a synapse with interneuron, that will make a synapse with the anterior spinal horn, or we call alpha motor neuron, which will supply the muscle, and the muscle will contract, and you will have contraction of the muscle and withdrawal of the limb. This is typical sensory reflex. Here again you are stimulating cornea. The sensory pathway is fifth cranial nerve. It goes to the pons, and motor pathway is again a seventh cranial nerve, which will give rise to contraction of orbicularis oculi. This is again a superficial reflex, but it is at the level of brainstem, so we call as a brainstem sensory reflex, or we call corneal and conjunctival reflex. So we have got two types of sensory reflexes, concerned with spinal and concerned with brainstem. Concerned with brainstem we call the brainstem reflexes, and they are related with cranial nerves, while in a spinal cord we call spinal reflexes, and as you are giving a sensory stimulus they are called as sensory reflexes. Now if we go exactly to the pathway of sensory reflexes, that is from sensory receptor, the fiber will go all along by the peripheral nerve to posterior root ganglia, which is a bipolar. So other part of the axon will go to the posterior root, will enter the spinal cord at the level of posterior horn. Then it will divide into two, one which will take part in a local reflex arc, where it will make a synapse with interneuron, and that interneuron will make a synapse with alpha motor neuron, and that alpha motor neuron will supply extrinsic fiber of the muscle, and that will give rise to contraction of the muscle. while one fiber will cross to the opposite side in anterior spinothalamic tract, or one group of fiber may run along the posterior column on the same side, and then at the level of nucleus cuneatus and gracilis, it will make a synapse in nucleus cuneatus and gracilis. From there, the fiber will go to the thalamus, will be crossing to the opposite side, while this lateral spinothalamic tract will run all along and it will end in a opposite side thalamus. And from thalamus, thalamocortical fiber to post-central gyrus of parietal lobe, and from that parietal lobe you will have a connection to primary motor area, which is situated in the frontal lobe, that is the precentral gyrus region. From there the pyramidal tract will descend down, which will cross at the level of medulla. So now impulse will come back to the same side in the form of the descending tracts, that is we call as a lateral corticospinal tract, which will make a synapse with interneuron, where you are getting a synapse with posterior nerve root fiber, and depending upon that it will give rise to contraction of this extrafusal fiber. So there is one pathway which is taking part in this superficial reflexes is ascending tracts in the form of lateral corticospinal tract, or in some where we give a kinesthetic stimulus, that is posterior column, and descending tracts, that is corticospinal tract, will take part in stimulation of anterior horn cell. So in a superficial reflexes, these two are very important. As far as brainstem is concerned or concerned with cranial nerves, we have already discussed in cranial nerves, that is pupillary reflex, which can be direct, indirect, and accommodation response. While concerned with 5th and 7th cranial nerve, that is corneal and conjunctival reflex. Concerned with 9th and 10th cranial nerve, that is palatal reflex and pharyngeal reflex, or we call that as a gag reflex. And ciliospinal reflex is concerned with skin, that is sensory stimulus, which is given to the skin in the neck region, and motor pathway is via sympathetic fiber, which will innervate the perpendicular fiber of iris, or we call dilator fibers of iris. These are all the superficial reflex concerned with cranial nerves, or we call with brainstem. While with spinal cord, abdominal reflex, crematic reflex, and plantar reflex. These are the three common reflexes which are being elicited, out of which the crematic reflex will be elicited only in case of a male, but abdominal and plantar reflex will be elicited in both male as well as female. Very rarely anal reflex and bulbocavernous reflex are being done. Mainly we pay attention to abdominal reflex, crematic reflex, and plantar reflex. We'll be going through all those. Doll's eye movement and caloric reflex are again mainly reflexes concerned with cranial nerves and concerned with brainstem, and they are very important in a person with a altered level of consciousness, particularly unconscious person, where vestibular apparatus is the main stimulant part. So vestibular apparatus is a sensory input, and motor pathway is concerned with 3rd, 4th and 6th cranial nerve. That's why it is also called as a vestibulo-ocular reflexes. So it is also part and parcel of a superficial reflex, but concerned with cranial nerves. So that is another reflex which is being elicited mainly in unconscious person. So conjunctival, corneal reflex, visual reflex, that is direct and indirect pupillary reflex, and accommodation reflex. All this we have already discussed in pupillary reflex in cranial nerves. I am keeping this particular slide At your leisure time, you can go through again, revise this particular, very frequently asked in your oral, and very commonly can be asked in your theory also. And very commonly you will come across in your everyday practice. And you must be aware of all these reflexes, that is conjunctival and corneal reflex, which is concerned with 5th and 7th cranial nerve. 5th is sensory, 7th is motor. While pupillary reflex, 2nd is sensory and 3rd cranial nerve is motor, but it is a parasympathetic system of 3rd cranial nerve. So that will be direct as well as indirect pupillary reflex, and we will have another reflex we call as the accommodation response or near reflex or convergence reflex. So these are some of the superficial reflexes concerned with cranial nerve. And then we do palatal reflex, or we call pharyngeal reflex. Together we call as a gag reflex, where 9th is sensory, 10th is motor. So it is a very important in case of brainstem lesions. I've already discussed in detail. Now we will be discussing mainly superficial reflexes concerned with spinal nerve, of which one which is almost most important reflex, which gives you an idea regarding upper motor neuron or lower motor neuron lesion, that is plantar reflex. Just at present I am mentioning the level, etc. Then how to elicit and what will be the response, but we will be discussing in detail in the further slides. So plantar reflex is concerned with alpha S1, and we will be discussing in detail how exactly you elicit the reflex as well as the response. The response is mainly in the form of a plantar flexion, adduction of all toe, plantar flexion of the great toe, plantar flexion of the foot part, then flexion at knee, flexion at hip, and simultaneously there is a contraction of iliotibial tract. So all these are part and parcel of plantar reflex. Now this is very important, because if your method is wrong, you will not be able to elicit the plantar reflex. By and large, it should be elicited in a supine posture. You will have to hold the ankle gently, not very tightly, and then you scratch the plantar surface of the foot from heel laterally towards the small toe with a blunt object, particularly the blunt end of the key or maybe a blunt end of the hammer, and then you can extend that stimulus to the base of the great toe. So from heel towards little toe and then medially up to great toe. This has to be again gentle, and during that stimulus you watch for movement of great toe. If it is plantar flexion with adduction and plantar flexion of great toe as well as all the other toe and plantar flexion of the foot, we label that as normal, or we say that plantar reflex is flexor, plantar flexor. But if there is a plantar extensor, meaning if the great toe undergoes extension, there is abduction of all the toes, there is extension of other toes, there is an extension of plantar, or we call dorsiflexion. It is labeled as Babinski sign. By and large, we don't use the word Babinski sign positive. Babinski sign means it is plantar extensor, or we call dorsiflexion of the plantar foot. Dorsiflexion of the foot. This is what is being done in a case of a plantar reflex. And we'll be discussing in detail in which condition you get plantar flexion, in which condition it is absent. So interpretation we'll be doing separately. As far as the abdominal reflex is concerned, the root value is 7, T7 to T12. Best way is always in supine posture. You uncover the abdomen, expose the muscle, and ask the person to relax well. You use a blunt object again in the form of a blunt end of hammer or keychain, not keychain, key, blunt part of the key, or you can use even the uh, what we call is a tongue depressor, etc. And with that, whenever you stroke, we'll be showing you in a diagram, the stimulus has to be from lateral to medial towards the umbilicus, and you have to observe the contraction of abdominal muscle, and you will see withdrawal of the umbilicus towards your stimulus because you are stimulating from lateral to medial, and it should be in all the four directions. That is horizontally at the level of umbilicus, vertically from epigastrium towards the umbilicus, and in a four quadrants in the angle. So this will be the stimulus and you will be looking for the response. We'll be discussing the interpretation of the responses. By and large, scapular reflex is not usually being done, but just for information, the root value is C5 to T1. You have to stroke with a again blunt object, skin in the interscapular region, and the response will be contraction of the suprascapular and infraspinatus muscle, leading to retraction of scapula. Anal reflex is again usually not done. The root value is S3, S4. This becomes of importance whenever you are suspecting the damage in a conus medullaris or in a person with cauda equina lesion, where you are scratching the skin near the anus and the response is contraction of the anal sphincter. Crematic reflex is L1, L2. You have to expose the part, that is inguinal region, right up to mid thigh. Two legs should be separate. You stroke the skin and stimulus should be from anterior superior iliac spine towards the pubic symphysis with a blunt object, and you look for contraction of the crematic muscle and lifting up of the testis. Also, you can scratch the skin along the inner part of the thigh, and you have to scratch from below upward, from the thigh towards the pubic symphysis, and the response is contraction of the crematic muscles and uplift of the testis. This is crematic reflex. So we usually demonstrate plantar reflex, abdominal reflex, and crematic reflex. Crematic reflex and bulbocavernous reflex will be elicitable only in male. Bulbocavernous reflex is S3, S4. Again, this is of help in case of a conus medullaris lesion and to differentiate it from a cauda equina lesion, where stimulus is in the form of a pinching the dorsum part of the glans penis and response is in the form of a contraction of a bulbocavernous muscle. These are the superficial reflexes concerned in any patient. So normally we elicit plantar reflex, abdominal reflex and crematic reflex. Crematic reflex is in a male. Scapular and anal reflex are usually not done. Very rarely they are done. By and large, anal reflex we commonly do if we want to differentiate conus medullary lesion from cauda equina lesions, or the lesions in those area we call as the lower end of the spinal cord and cauda equina. The lower end is called conus medullaris. Bulbocavernous is the same. So anal reflex, crematic reflex and bulbocavernous reflex are very uncommon, but crematic and bulbocavernous is possible only in male. Now, interpretation as far as superficial reflex is concerned, very simple. If reflex arc is broken, means if sensory pathway, center or motor pathway that is efferent. If any one of these three is damaged, superficial reflex will be affected and it will be absent. If superficial reflex is elicitable, that means local reflex arc is intact. Now, it will be difficult to elicit superficial reflex if your technique is wrong, or superficial reflex will not be elicitable, or we call absent. We have already mentioned if there is a damage to sensory root, means either the skin part or peripheral nerve or peripheral root, that is peripheral root ganglia, or damage to spinal cord, or damage to ascending tract, descending tracts and corticospinal tract, that is upper motor neuron. The superficial reflex, particularly abdominal and crematic reflex, will be absent on that side, on that damaged side. That is damaged side of the spinal cord, damaged side of the corticospinal tract, and damage to sensory root or motor root or spinal cord on the side of the damage. And at the level, it will be absent. Also, it will be very difficult to elicit if a person is obese, or if a person has got tense ascites, or there is a gross distension because of any other pathophysiology where abdominal wall is extremely stretched, or there is a very lax abdomen opposite of that. If abdomen is very lax, particularly in an old individual or multipara, or recovery after tense ascites, or reduction in weight in an obese individual. Also, it will be extremely difficult to elicit in person with anxiety and non-cooperative person, as well as psychiatric person. So indirectly, superficial reflex is present, normal. If it is absent, either wrong technique, or it is difficult to elicit in case of an obese individual or tense ascites or gross distension, or opposite of that very lax abdomen, or person is non-cooperative, or person is having anxiety, or person is having a psychological disorder, etc. And it will be absent if there is a damage to sensory nerve root, sensory receptor in that skin area where reflex has to be elicited, or spinal cord on the same side at the level of reflex arc, or motor root at the level of reflex arc, or if there is a damage to ascending tracts, particularly lateral corticospinal tract, ascending tract, lateral spinothalamic tract, or sometime even posterior column, which is taking part in some of the reflexes, particularly if there is a vibration sensation is being utilized, or you are utilizing kinesthetic sensation, and if there is a damage to corticospinal tract, either at the level of cortex or at the level of corona radiata or internal capsule or corticobulbar tracts, or even damage to corticospinal tract up to what we call as any level in spinal cord. Particularly as far as abdominal reflex is concerned, T8 to T12 is the abdominal reflex level, and for crematic reflex it is L1, L2. For plantar reflex it is alpha S1. So this will be the level, and we have already mentioned present, absent or not elicitable. There is nothing like exaggeration. Exaggeration of the reflexes will be very common in a non-cooperative individual or person who are anxious and person who are oversensitive. So this is the way we elicit the abdominal reflex. Stimulus is always from lateral to medial, and at the level of umbilicus it is T10, at the level of xiphisternum it is T8, and at the pubic symphysis it is T12. So at this level it is T10, and above that T8 is xiphisternum, and T12 is pubic symphysis. So you give a stimulus from lateral to medial, and you can use a blunt object or you can use a cotton swab, and it is always elicited in a supine posture. You uncover the area, let the muscle relax. Person should be absolutely relaxed. You use a blunt object, particularly like a key or a blunt end of the hammer, or you can use a cotton, and you have to stimulate from lateral to medial or parallel to the costal margin or along the inguinal ligaments, and look for the contraction of abdominal muscle. We already mentioned the abdominal reflex will be absent if there is a damage to lower motor neuron, that is sensory root, spinal cord or motor root at the level of damage. And if there is a damage above the level, that is above T8 spinal cord segment, then also abdominal reflex will be absent on the side of the damage. So in case of an upper motor neuron damage, if the damage is above the level of the reflex arc, it will be absent, and it will not be elicitable in obesity, elderly individual, abdominal distension, lax abdomen, tense ascites, etc. Crematic reflex also same thing. We already mentioned how to elicit. It will be absent in case of upper motor neuron damage, as the level is lumbar 1, lumbar 2. So if there is a damage above the level of T12, at T12 and above, crematic reflex will be absent on the side of the damage. And if there is a damage at the level of lumbar 1, lumbar 2, which will be a lower motor neuron damage, crematic reflex will be absent. And some of the pathophysiology, which is if it is present in the scrotum, like hydrocele, or there is an indirect inguinal hernia, or if there is any pathophysiology in the inguinal region also, like indirect inguinal hernia, and it is big enough, you will not be able to see the contraction of crematic muscle and ascents of testis. So here it will be difficult to elicit, while in lower motor neuron it will be absent, and upper motor neuron on the side of the damage of corticospinal tract, it will be absent. So if there is a damage to the right side of the spinal cord, right side crematic reflex will be absent. And if there is a damage to left cerebral hemisphere and left side corticospinal tract up to medulla, where it crosses to the opposite side, the opposite side crematic reflex will be absent. Same thing will be there for bulbocavernous reflex, as we usually don't do, and it is elicitable only in male. So do remember, in upper motor neuron lesions above the level of S1, it will be damaged, and if there is a damage at the level of S1, S2, crematic reflex, anal reflex and bulbocavernous reflex both will be affected, and this will happen very commonly in a conus medullaris lesion. Anal reflex, so you can have damage to S2, S3, S4 segment in cauda equina lesion. You can have absence of anal reflex as a lower motor neuron damage. The most important reflex is a plantar reflex. This is how you elicit. We'll have some of the video clips which will tell you how exactly you elicit. We'll be showing you that. Root value is alpha S1, and we have already mentioned that the response in a normal person is plantar flexion of the great toe, plantar flexion of all other toes. There is an adduction of all toes, plantar flexion of the foot, flexion at knee, flexion at hip, and contraction of some of the muscles, particularly the muscles which produces flexion at knee and flexion at hip, and simultaneously there is also contraction of iliotibial tract. So that will also produce contraction together. But if there is a damage to corticospinal tract above the level of alpha S1, that is above L4 level, you will have a plantar extensor. And whenever you get a plantar extensor, it is called Babinski sign or Babinski reflex, or we call plantar extensor, in which you will have extension of the great toe. Here you can see there is an extension of the great toe. There will be fanning of all the toes. There will be extension of all the other toes. Plus, foot will undergo plantar extension. There will be withdrawal at knee, at hip, and there will be contraction of also iliotibial tract. This is a part of Babinski sign, or we call Babinski reflex, and that is seen in upper motor neuron lesion. We'll be mentioning the importance of all those findings. So, in a flexor, we already mentioned plantar flexion of all toes, plantar flexion of great toe, adduction of all toes, plantar flexion of foot, contraction of iliotibial tract, that is the lateral side of the thigh. And in sensitive person, there will be withdrawal, that is contraction at knee, and contraction, that is flexion at knee and flexion at hip. This is called normal response. And if this is seen, we say that plantar reflex is normal. In case of an abnormal response, that is we call Babinski reflex or Babinski sign, or we call plantar extensor, where there is a plantar extension of all toes, plantar extension of great toe, you can see here. All the toes fans out, so we call abduction of all toes. There is a plantar extension of foot, and there will be absence of contraction of the iliotibial tract. And in a sensitive person, you will have a withdrawal of or flexor contraction at knee as well as hip. This will be the part and parcel of Babinski sign. There are other methods of also eliciting the Babinski sign, that is we call Chaddock sign, where you tap over the lateral mediolus and there is an extension of great toe. In Hofmann test, you apply a firm pressure on the shin of the tibia, you get contraction of extensor hallucis longus, which will produce extension of the great toe. Again, that is one of the signs in case of upper motor neuron palsy. In Gonda's test, you flick the terminal toe. In Rosomilo, you tap over the terminal toe. In Gordon test, you squeeze the calf muscle. And in Schaefer test, you squeeze the tendo Achilles. These are all the different tests which are being done, and they will give rise to what we call as extension of the great toe, and it is one of the signs which you will not be able to elicit if there is an absence of great toe. These are some of the alternative methods where you can demonstrate by great toe extension in case of an upper motor neuron palsy. These are alternative methods. But when the great toe is absent, usually you look for the contraction of the iliotibial tract. So, absence of plantar response, totally plantar response is not elicitable, it is not flexor nor extensor. That will be very common in a severe peripheral neuropathy, that is loss of sensation in the sole part of the foot, or there is a paralysis of extensor hallucis longus, or if there is a damage at the level of alpha S1, which we call as a lower motor neuron. So in these cases, the plantar reflex will be absent, or we'll say that it is not elicitable. But ideal word will be absent. It will not be elicitable in person who are non-cooperative person, or person who are hypersensitive, or person where your technique is wrong, your stimulus is wrong. In that case, you will not be able to elicit the plantar reflex. Now, flexor response is normal. Absent, we have already mentioned, if there is a severe sensory loss, particularly in case of a peripheral neuropathy, where the sensation from the plantar surface of the foot is nearly lost, or if there is a damage at the level of alpha S1 in a spinal cord, plantar reflex will be absent. But it will be extensor and unilateral extensor in case of cerebral damage, we call cerebral hemiplegia, where you can have a damage to cerebral cortex or corona radiata or internal capsule or corticospinal tract up to medulla on opposite side, and in a lower part of medulla. From that lower part of medulla, right tail in the spinal cord, it will be the same side. Also, you can get a damage to this particular, as far as cerebral cortex is concerned, in case of a stroke, or you can get a damage to deeper structure also in case of a stroke, or you can have in other disorders like multiple sclerosis or a demyelinating disease, or also in case of a tumor, trauma, etc. Also, you can have a damage to one side of cerebral hemisphere if there is a damage to anterior cerebral artery, which will produce a damage to lower limb, that can produce again lower limb being involved because of a corticospinal tract damage, and that can be with again plantar extensor. So this will be some of the causes as far as the pyramidal tract damage is concerned. But other than pyramidal tract damage, if a person is in a deep sleep or coma, or in a newborn children before he starts walking, during anesthesia, post-ictal coma, in this condition, bilateral plantar will be extensor. In case of a pseudobulbar palsy, because there is a bilateral upper motor neuron damage, because of repeated stroke, the plantar will be bilateral extensor, or any condition which produces damage to spinal cord and produces bilateral lower limb palsy, we call paraplegia. In those cases also, you will have a bilateral plantar extensor. So these are all the conditions where you will get a bilateral plantar extensor. Now here is a video recording which will show you how you demonstrate the plantar reflex, and there are some reflexes which are demonstrable in this particular person. I think that is not working. Sorry. This is not working. Sorry. Sorry, I will have to show you. This is a deep tendon reflexes. We have already uploaded one in a deep tendon reflexes. So I'll skip this particular. I've already uploaded this particular part. So this is a part of a deep tendon reflexes. Sorry for interruption. I've discussed everything of this in another video in a deep tendon reflex. I don't know why this is not working. Sorry, something has gone wrong. I'll be putting all this, I'll be showing you one by one. Sorry. So I'll just show you all this together. Sorry, something has gone wrong. So all this I have discussed previously. Sorry for that. After this, in continuity, I'll be putting together. So thank you for taking out time. I know that your time is valuable and I appreciate that for spending some of the time with me. So now I'll try to put all those things together one by one. Sorry for all those inconvenience. Sorry, I'll do it as fast as possible. Okay, now I'll be showing you some of those, particularly we don't have here. Sorry, one more thing regarding a plantar reflex. We'll be showing you first, say, uh, the increased tone in the muscle in upper motor neuron.
Rigidity of the extensor muscles of a joint that gives resistance to passive flexion,
Now this is
but
a demonstration
gives a
of
way
what we call as a
abruptly
classical
to
clasp
allow
knife
easy
rigidity.
flexion
You can
on
see initial
exertion of
resistance and
further
then sudden
pressure.
give way.
This movement resembles that of a clasp knife.
See resistance and then sudden give way. That is clasp knife rigidity. Now this will be a cogwheel
A
rigidity.
series of catches appears during passive flexion of the extremities. This is called as a cogwheel rigidity.
You can see
This
this
is
is
a
a
typical
demonstration.
feature
This person doesn't
associated
have.
with
You are
Parkinson's
getting
disease.
in between little
Reflex
resistance. That was a demonstration of cogwheel rigidity. Now this is another demonstration of cogwheel rigidity. Now you can see that a person is trying to extend. During extension, in between you are getting a jerky movement. This is a typical cogwheel rigidity. You can see a cogwheel rigidity. Very nicely demonstrable. Very nicely demonstrable. During extension at elbow. So you can demonstrate at elbow and you can demonstrate at wrist. Cogwheel rigidity will be very nicely demonstrable in those two regions. Very nicely. So that was a cogwheel rigidity. Now I'll show you a clonus. Demonstration of clonus.
Now see the video.
You can see he's eliciting the clonus. You apply a jerk and maintain that. Now you can see that there is a contraction. This is sustained clonus.
Similarly, patellar clonus can be
For
demonstrated by
patellar
sharply moving
clonus, you
patella
will have to
downwards
push the
with
patella
patient in
down.
supine position. What
And
is mechanism for clonus? It is due to inhibition of upper motor neuron system to
over the
local
local
stretch reflex,
stretch reflex.
and it can be seen in conditions like cerebral palsy, stroke, multiple sclerosis, spinal cord damage, and sometimes in hepatic encephalopathy. So friends, this was all about clonus.
There is another video where we'll be able to show you clonus plus Hofmann sign.
Mr. Nightingale. Mr. Nightingale is 59 years old, comes to us today with a diagnosis of progressive weakness in this leg with some osteoarthritis in the right knee. Interestingly enough, when he's evaluated today, we find some other neurological signs and symptoms that kind of raise a red flag and indicate to us that we probably need to look into this a little bit deeper. Back in 2001, he underwent a cervical spine surgery for severe stenosis at C5, C6 and had a fusion. And recently has noticed this progressive weakness in his leg. So I'm not going to go through much more history than that, but I will show you some of the physical findings that we've had. All right. So I'm going to start off with his reflexes first, and we're going to go upper for now, and then we're going to work to the more significant areas. So C7.
You can see these reflexes.
Quite hyperreflexive.
These are hyperreflexive. You can see this is clear cut.
C6. So all about 3+. Equal to this side.
You can see this is hyperreflexia. Brachioradialis, bicep, tricep.
L4 on the left side.
You can see here in knee,
Hyperreflexive.
hyperreflexive. Even ankle also.
Okay, now we'll be careful on this side. Okay, so L4.
You can see now clonus is
Okay, and
elicited.
look, we have some clonus in the leg. We can stop it by pushing on the Golgi tendon organ just above the knee. That's a significant sign of some sort of myelopathy going on or upper motor neuron lesion.
Very clearly
So
you
what
can
we'll do here is
demonstrate the
we'll gently
clonus.
dorsiflex him, we'll check his S1, and it actually activates his L4. He's so hyperreflexive. He's unable to dorsiflex the big toe. He's unable to dorsiflex the foot against the tone there. And his inversion and eversion are about 2+/5. Another very interesting finding, and we'll zoom in on this one, is that he has
Now
a
he's
very
showing
positive
Hofmann
Hofmann
test.
test. So I'd like you to relax your hand. Okay.
This is a
And what
Hofmann
you do
test.
is
You
hold
flick the middle finger, we'll get the
flick
contact.
it, and observe the thumb and the index finger coming together.
This is Hofmann test.
So that's kind of like the Babinski of the upper extremity. The same thing happens on this side.
Some people say Babinski of upper extremity, yes. You can see the flexion of finger and adduction of the thumb.
With that in mind, we need to be somewhat suspicious that he is getting more cord compression. And my thought is that it's in the cervical spine because he's having the positive Hofmann's here, the hyperreflexia here, hyperreflexiveness down here, and also on this side has a positive Babinski sign. The toes splay right out, they don't curl down. So we are going to consult with the patient's PCP.
So that was clonus with Hofmann's. This is also clonus with Hofmann. This is another patient.
And I have with me Carmen today. Carmen comes in with a very interesting presentation. She was initially seen by one of our therapists in one of our other offices for cervical spine pain and headaches, right? You're having neck pain and headaches. She also had this progressive loss of balance, in coordination. She's starting to shake a little bit. She also had an episode a couple of years ago where she had surgery, lost a considerable amount of weight, lost about 50 pounds over the last 2 years, and she's weighing, what, about 94 to 95 pounds right now? And, so you've gained a little bit there lately. Okay, great. And so, we started to evaluate her neck, noticed that doing cervical spine clearing and doing some neurologic testing, found some unusual presentations. So what I'm going to do first is just kind of show you what we found. And then the other questions we had was, do you have a family history of MS, Lou Gehrig's disease? You haven't been out of the country, foreign country. You haven't been bit by a tick or anything like that. So nothing unusual there.
Yeah, brisk reflexes.
I'm going to have you relax that arm, and I'm just going to check her C7 here. And you can see she kind of reacts. Even her lats kind of kick in here, and she gets really kind of hyper-reflexive down in this area. It's a very unusual presentation. I'm going to check your biceps. I need you to relax. C5. We're hyper-reflexive there. C6.
This is
Okay, so
supinator.
see how quickly she reacts there. So from there, she had the same presentation on that side. Then we went down here because she's hyper-reflexive. We thought we would do the lowers. Okay.
This is also
She's
hyper-reflexive.
quite reactive. And notice she has kind of a little clonus there with that. S1. We do her reflex, and she even develops clonus on the left side when we do that. Okay. And if I give her a little dorsiflexion really quick, it really fires up. And she even goes, she gets
The opposite side
hypertonic.
also, without even stimulus, there is
So
a
that will
clonus.
calm down after a little
This is
bit.
severe
Her sensation's good, upper and lower extremities.
bilateral
She has
upper
a
motor
negative
neuron
cervical
damage.
spine compression test. She doesn't quite like extension of the cervical spine. That does give her some trouble up here. She's been having some issues with her eyes over the last year to 2 years, and they've been dealing with that.
Then this is a lead pipe type of a rigidity. Same resistance all throughout, and resistance in both flexion as well as extension. This is called lead pipe type of a rigidity, which you will get in case of a Parkinson disease, or we call extrapyramidal damage. Typical, very, very typical. Resistance in both movement, flexion as well as extension. Much better demonstrable. Cogwheel and both will be demonstrable at elbow. At elbow. Now I'll be showing you plantar reflex.
No, it is an extensor plantar reflex which is seen in upper motor neuron lesions due to injury or affection of the corticospinal tract due to any other reason. To revise, the corticospinal tract is a descending motor tract which originates from the cerebral cortex, passes
This is the
via
pathway.
brainstem,
These are
reaches up to
ascending
the spinal
tracts,
cord, from where
and
the
this is
whole motor neuron
corticospinal
begins
tract.
in the form of peripheral nerves. These fibers maintain inhibitory control
An
over the
ascending
spread
tract
of
can be
impulses
spinothalamic
from
tract,
dermatome which is stimulated to
or
other levels
it
of
can
the
be posterior
spinal
column.
cord. For example, in eliciting the plantar reflex, we give
This is Babinski.
nociceptive stimulus to the
This is
lateral
flexor.
border of foot, which is the S1 dermatome, which normally causes plantar flexion mediated through S1 and tibial nerve. So basically, plantar reflex is a spinal reflex where afferent is S1 and efferent is via S1 and tibial nerve, root value L4, 5, S1, 2, 3. Once the corticospinal tract is affected, the inhibitory control is lost and firing spreads onto L4, L5 anterior horn cells, leading to the contraction of toe and extensors, that is, extensor digitorum longus and extensor hallucis longus via the deep peroneal nerve. The Babinski
These are the
sign
5
has
components of
components.
Babinski sign.
Dorsiflexion of the great toe with or without extension and fanning of the other toes, dorsiflexion at ankle, flexion of knee, and contraction of the
Tensor
tensor
fasciae
fasciae
lata.
lata. One must remember that only the extensor plantar response is called as Babinski's positive. A flexor plantar response is not known as Babinski's negative. So there is no term as negative Babinski sign. Babinski sign is the same as Babinski's reflex and it is a superficial reflex. We will show various superficial and deep reflexes in a subsequent video. To elicit it, the plantar surface of the foot should be free of any pathology. Eliciting equipment should be sharp but non-traumatic, for example the tip of the hammer handle or preferably the tip of a key. Make the patient lie relaxed on a couch, explain the procedure, and stroke the lateral plantar side of the foot from the heel to the toes and then across the metatarsal pads to the base of the big toe.
This is a technique.
So
Now
this
you
is
can
how
see
the
here
Babinski sign
there is a
is
full
elicited by
demonstration
stroking
of
the
all the
lateral
different
border of the foot
signs.
up to the base of the toes. Actually, the
You
lesion
can
in
see
this
there is
patient
an
was so
extension
severe
of the great
that
toe,
even
there
with
is
the
a flexion
slightest
at
stroke on the
knee,
lateral border
and there is
would
flexion at
miss
hip
the
also.
extensor plantar response. Sometimes even this much produces the response and you don't need to complete it up to the base of the toes.
You
Even
have
the
to hold
removal
that
does
ankle
involve
and then try
completing it
to
up to the
elicit.
base of the toes.
Base is always in
What if the
supine
foot is
posture.
infected or injured and we cannot elicit the Babinski sign? In that case, there are some other signs by which we can elicit the extensor plantar response, some of which are demonstrated here quickly.
These are the
Open
alternative
heel
method.
sign by
It is
rubbing,
open M
by rubbing
signs.
down
You
the shin of
stimulate
tibia.
the tibia, sheen of tibia, and you get
Gordon sign
extension.
by squeezing the
This is
calf
squeezing
muscles.
the calf muscle. This is called Gordon's. You can see plantar extension.
Caddock sign by stroking the
When you
lateral
stroke the lateral
malleolus.
malleolus and you get an extension of the great toe, it is called Chaddock sign. You can see extension of all toes.
Bing
This is Bing
sign by
sign.
pricking the
That is, you
dorsum of
pinch,
foot.
you just give a stimulus on the dorsal surface and you get an extension of the great toe.
Clonus
Conda is
sign
squeezing
by forceful downward stretching of the second or the fourth
second
toe.
toe, or that is downward, or even a terminal toe.
And finally the Schaeffer sign
Schaeffer is
by pressing the
squeezing the
tendo Achilles.
tendoachilli. That is Schaeffer. These are all the different tests
Then
which
there are
can be
some
done.
other signs
These
which
are
are
other
not
alternative
generally
tests
asked in the examination
which can
but
be
are
done.
mentioned in case you wish to know.
And when you look at
So what are the
tensor
advantages of
fasciolata
eliciting the
contraction,
Babinski sign? First, it is a simple bedside clinical sign. Second, it has an improved accuracy when compared against electromyographic findings. And a true upgoing toe sign is reproducible, unlike voluntary withdrawal response, which the child might not be able to repeat in the same manner. But one must remember that sometimes there is no response to stimulation, and this is referred to as neutral response. This response, however, does not completely rule out the pathology. So when can it be falsely positive? There are a plethora of causes, but as pediatricians we must know that age less than 1 year is an important cause, rather up to 18 months, due to incomplete myelination of the
these
cortical
are other
spine.
causes where the plantar reflex will
Sometimes
be
it can
falsely
also be
positive,
positive
means
in deep
it
sleep,
will be extensor.
coma, under the effect of general anesthesia, or even during the post-ictal phase of seizure. Remember, one common factor is that the corticospinal tract
Post-ictal
is
stage,
temporarily
narcosis, alcohol
lost
intoxication,
its negative control on the
hypoglycemia,
spinal cord in all these
hypnosis,
physiological states.
apneic phase, physical exhaustion,
So would you like to
etc.
know who discovered it? It was a neurologist, Joseph Francois Felix Babinski, who originally described it as the toes phenomenon or phénomène des orteils, but later eponymously referred to as the Babinski sign. Thank you for watching till the end and have a good day.
Wonderful demonstration. And if you get contraction of a tensor fasciolata, that is given a name, Brisard sign. These are all the different signs which you can see in a person with upper motor neuron lesions. Now I'll show you Hofmann sign. We have already demonstrated, almost we have finished.